Uh, this training program is to equip clinicians with the skills and knowledge they need to participate in the Sydney Health Partners Emergency Department trial. My name is Professor Chris Maher and I'm one of the investigators for the trial. This presentation will take about 5 to 10 minutes. The SHaPED trial, or the Sydney Health Partners Emergency Department trial, is testing the implementation of a new model of care for acute low back pain. This model of care was developed by the New South Wales Agency for Clinical Innovation. Originally, the model of care was developed for use in primary care setting, and we're adapting and using this model in the emergency department. We're doing this because there are increasing presentations to the emergency department for people with acute low back pain. The model of care has got 10 principles, and the ones which I wanted to draw your attention to are going to be talked about slowly here. So the first principle is that each of the patients who come into the emergency department with an episode of acute low back pain need to be comprehensively assessed. So you need to take a full history and physical examination. And the reason for this is to identify the small number of people who have a serious pathology such as infection, fracture or cancer, which is the cause of their low back pain. And these people are treated completely differently to the rest of the patients. And that's a very small number of people who've got a serious pathology. The next principle that is important is for patient education to be provided to each of the patients. And the reason for this is that when people turn up to ED, they're often anxious, they're distressed, they're unsure what's going wrong with their back. And so a confident clinician is really helpful here to explain to the patient what is happening to them, the likely good prognosis if they've got non-specific low back pain, and sort of help them on the way to recovery. The next principle that I wanted to draw your attention to is the idea around the appropriate use of analgesic medicines. And so currently the thoughts are that you should avoid using complex medicines such as opioids, but instead start with fairly simple analgesics. So beginning with something such as paracetamol or an NSAID, rather than starting with something such as an opioid. The last principle that I wanted to bring your attention to is principle 9, and that is that for these patients, we need to make sure that they're reviewed appropriately. And I'll talk later about how we've set up a back clinic for each of the hospitals so that you can arrange for your patients on discharge to be seen by an experienced rheumatologist or physiotherapist to help them on their path to recovery. These are some data here for what's happening when patients present to Sydney Local Health District emergency departments. And so these are looking at people who've got non-specific low back pain or sciatica, so the two most common forms of low back pain. What you can see here is their average age, the number of presentations, and the number of people who are admitted. And you can also see, for the people who are admitted, the average length of stay. So the important point here is that we're seeing a lot of patients with back pain in emergency departments, and in contrast to what guidelines are suggesting, we're admitting a large number of these people as inpatients. And once they're in there, they're staying for a long period of time. And that approach is contrary to most guidelines. The usual approach is that these people are best managed out in community care settings because the treatments available there are just as good as the treatments that can be provided as an inpatient. So keeping these people in hospital isn't giving them any additional benefit. In terms of the way these people are being managed, they seem to be being over-medicalised. And so just to explain that point, although the guidelines suggest that if you've got acute low back pain, and most of these people have got non-specific low back pain, you should avoid using an opioid, you shouldn't scan them. What's happening is the opposite. So about 2/3 of people with non-specific low back pain who arrive at the ED get prescribed an opioid, and that's more commonly a strong opioid such as oxycodone. And there are lots of downsides with that, which I'll explain in a future slide. A lot of these people are also getting a scan, so about 40% of people with non-specific low back pain are being sent for a scan, whereas the guidelines suggest that none of these people need to be scanned. And the third point in this graph is that it shows the number of people who are receiving lab tests. And so if these people have got non-specific low back pain, these people don't need lab tests, but unfortunately about 1 in 4 are being sent off for lab tests. In terms of opioids, we now understand they're not as good as we used to think they were for managing acute low back pain. So we now understand that there are no clinical trials that have tested the efficacy of an opioid for acute low back pain. So at this point in time, we're unsure whether they actually work for acute low back pain. There have been some trials which have tested whether using an opioid strategy is superior to non-opioids for back pain and knee pain. And what they found is quite surprising. In contrast to the view that opioids are very powerful painkillers, they don't seem to provide any more analgesia than non-opioids. What we do understand is that these medicines have a high rate of harms associated with them. So things such as dependence, opioid overdose and death are reasonably common after taking an opioid medicine. This statistic is looking at the number of people who are still taking an opioid 12 months later. And surprisingly, 10% of people who are prescribed an opioid are still taking an opioid 12 months later. So there is a large risk of these people becoming dependent on opioid medicines. And in the emergency care setting, overdose due to an opioid is the 8th most common cause of death after an emergency department discharge. So there's now lots of good information for why we should be a little bit more careful in prescribing opioids to people with low back pain in the emergency department setting. A really important role for the doctor and the nurse in the emergency department is to screen for the few patients, and as I said previously, maybe 5 or 6% of people who've got a serious form of back pain. So they've got things such as an epidural abscess, they've got cauda equina syndrome, things which are more serious, they're an emergency, and they're managed differently from non-specific low back pain. So these are the red flags that we're suggesting you should look for. So signs and symptoms of infection, a previous history of malignancy, unexplained weight loss, trauma, so significant trauma in younger people or minimal trauma in the elderly or those who've been on corticosteroids because their bones are more fragile than a younger person. If people have got features of cauda equina syndrome, so bladder and bowel disturbance, saddle anesthesia, we need to be aware of those sorts of people. Or if they've got severe neurological deficit. If people have got features of axial spondyloarthritis, such as pain and swelling in other joints of the body, skin rashes, those sorts of things, other systemic features, we need to be alert to those people who need further diagnostic workup. And another sign that's a red flag is when people are re-presenting to ED. So if there's been more than 2 low back pain presentations to the ED in the last month, we need to be a little bit careful about those people. In terms of the way we classify people with low back pain when they present to ED, we tend to put them into these 3 different categories. And so there's a group of people who've got serious pathology, and about 5 to 6% of people fit that box. And then people who have what used to be called sciatica, so these people have got lumbosacral radicular syndromes, about 10% of people. And the last group are the people who've got non-specific low back pain. And that's a diagnosis or diagnostic category that just means we are unable to specify the anatomical structure or the disease process that's causing their low back pain. So the majority of people who turn up to ED will fit into those last 2 categories. They'll have sciatica or non-specific low back pain, and those 2 groups of people can be considered in the same box really because the initial management is exactly the same. So the group that are different are the patients who present with serious pathology and they're managed in a very different manner than the people who've got radicular syndromes or non-specific low back pain. In terms of imaging, the contemporary advice is to avoid imaging for people who've got non-specific low back pain. And the reason for this is when they've done trials randomising people with non-specific low back pain to imaging or no imaging, those who are imaged don't get better outcomes. The obvious downside of unnecessary imaging is that you get exposed to unnecessary radiation, but there's also some other issues as well. Unnecessary imaging triggers a cascade of additional medical care, such as injections, opioid medicines and surgery. And another reason is that if we're ordering a lot of imaging in the ED department, it lengthens the stay in the ED and these people are more likely to be admitted. So there's a number of reasons why we need to avoid imaging in people who've got non-specific low back pain. A really important role of the doctor or nurse in the ED department is to educate the patient about what's happening with their back pain. So as I said before, these people are anxious, they're uncertain what's going on, they're scared. Once you've taken a full history and you're certain this person's either got sciatica or non-specific low back pain, you need to reassure the patient that serious disease is highly unlikely. There are no red flags there, you've done a full assessment. It's good news, although their back is very sore, they don't have a serious form of back pain. You should avoid using labels such as injury or disc trouble because it tends to be confusing for the patients. You should reassure the patient that most episodes settle pretty quickly. So by 4 to 6 weeks, nearly everybody has recovered. A usual statistical one that you can give the patient is that by about 2 weeks, about 50% of people have recovered. So people have horrible excruciating pain when they're in the ED. The good news is that these people recover very quickly. You should also advise them that they should use simple and safe analgesics in preference to an opioid. And the contemporary advice is that you should encourage people to stay active. Previously, we would put people to bed. what we want you to say now to the patients is to try and do as much as you can to try and keep going. We've provided for you in your training pack some patient education. So we've got fact sheets which will be available in the ED department, which you can give to the patient. We've also put together a website specifically for patients to give them good information about their back. And this runs through some information about back pain. It talks to other patients, and so they can share their experiences with patients. One of the strategies that we're implementing now is to use these heat wraps to try and help with pain relief. And so these are really simple. What you can do is you can undo them from the pack. They're activated when they're exposed to air. They're containing just iron powder and charcoal, and when these are exposed, when they're opened up, they gradually heat. And over about a half-hour period, they heat up to reach about a maximum of 53 degrees, and they last for about 12 hours. These are then applied to the skin using this corset that you can see here in the image. And once they're applied, they seem to provide similar pain relief as non-steroidal anti-inflammatory drugs such as ibuprofen. They've been tested in clinical trials and been shown to be just as useful as a simple pain analgesic medicine for people with acute low back pain. And we've trialled these in a number of ED departments, and the patients quite like them, and the nurses and doctors find them quite easy to use. So these will be available in each of the ED departments for you to give to your patients. The point that I made at the beginning of this is that when people leave the ED, for some of these people it's necessary to arrange a referral to a back pain clinic. And so we've set up arrangements at each of the ED departments so that you can arrange for early review within 1 week for the patients who need to be seen by someone else. So for example, at Royal Prince Alfred Hospital, we've got a back pain clinic, and you can just refer your patients to the back pain clinic. That's staffed by an experienced rheumatologist and a physiotherapist. The rheumatologist will again screen the patient to make sure there's nothing that's been missed, and then the physiotherapist can put together a rehabilitation program for these people to help them get further along the road to recovery. And so when you discharge the patients from ED, this is a really good approach. You're sort of not casting them away. You're giving them an option where if they're worried about the back, they can come back to a clinician who can make sure that they're recovering as you'd expect. If you're looking for additional tools for clinicians as well as the website for patients, we've put together a website for doctors, nurses and physiotherapists, and it includes all the information in this brief slide package. So it describes the model of care, it gives you a quick guide to how to manage low back pain, it summarises again the red flags, and it gives you some information about imaging. We've found that clinicians quite like this, particularly the videos where patients are explaining what's worrying them about their low back pain, and also the videos from doctors and nurses, explaining how they talk to patients, role-playing with real patients. And clinicians find that quite useful in terms of the language that should be used. If you have any questions about the trial, the email at the bottom there is for the SHaPED trial. So it's sph.shaped@sydney.edu.au. Any problems, any concerns, please contact us. Thank you very much for your time.